about the, I'll be very brief actually. This is topic is about classification of diabetic foot ulcers, and I'm so basically diabetic foot disease causes a growing global public health challenge, and as already we've discussed over so many sessions, so ulceration because of the neuropathy infection and ischemia. So diabetic foot ulcer is basically described as a presence of break in this skin of the foot with patients with diabetes that does not promptly heal. So of course the main things we've already focused on this. Offloading is the most common, inadequate offloading is the most common cause of failure to heal, and perfusion is the most critical element. So all the patients should be assessed for vascular disease and in diabetic foot, and wherever required should be treated. So ischemic ulcers that already Dr. Manir already discussed in the last talk that diabetic foot. So I'll be discussing few of them. So this Maggot and Wagner's has been the most used historically. It basically uses the wound depth as the measure, and despite its weaknesses, it has been used in a number of studies to see the association between grades and extremity amputations. So the different grades are like this, redness of skin is there, no ulcer is there. So preventive measures can be taken at this point. That is why we already focus the need for regular, one is the regular foot examination by the patient at home, and the other is the foot examination at every visit to the physician. So grade 1 is superficial ulcerization, and then deep ulcers, visible tendon or bone, and then the deep abscesses or osteomyelitis, and localized or forefoot gangrene, and then the entire gangrene. So this has been shown to have association with the amputation at 12 months. The grade mode is the chances of getting an amputation. So other is the University of Texas classification. It basically includes depth, presence of infection and ischemia or both, and still here LOP is not included, but it has it has been internally and externally validated in many series, and it has shown to be comparable reliability with the PDIS and Sinbad score. So other is the this perfusion extent depth infection sensation, which was designed by international working group on diabetic foot in 2003, and then updated. We got another latest version. We'll be talking about that. So different. I won't go into discussing the different dimensionality. And this is again one of another curative health services system classification, which was created in 2002. Again, depth, infection and gangrene was seen. It is basically a resembles like a modified Wagner scale, and again all studies have shown association with the classification and the target outcomes. So again, other DEPA, diaphora, and many more classifications are there, and to mention this site ischemia, neuropathy, bacterial infection area, depth is one of the classification that is being used for audit of population of ulcers. It is basically a modification of another SAG classification. So it has been used in by the UK National Diabetic Foot Care for audit, and again it has showed higher the score, lower chances of being alive, and diabetic foot ulcer free at 12 and 24 weeks. So this again international this society this is a classification basically only of infection and affecting diabetic foot ulcers, was originally developed as a part of PEDIS. It has 4 scores and it is basically for managing infected diabetic foot ulcers. So the recent most classification, this is given by inter-societal working group, again SVS classification also we say. This is wound in ischemia and foot infection classification. So basically system is threatened limb classification proposed in 2014, and this is focus is on stratification for 1 year risk of major amputation and predicting the likelihood for revascularization that would be required for wound healing and limb service. So it includes diabetic foot ulcer characterization using wound depth, then degree of ischemia using ABI scores, and infection as per the again the last diabetic foot ulcer infection classification we talked about earlier. And this classification has shown to predict multiple pertinent diabetic foot ulcer outcomes, including extent of healing, time to heal, and lower extremity amputation occurrence, and amputation free survival, and especially need for revascularization. And overall its use has been since been endorsed by many centers and societies worldwide. So basically this is the classification. So basically 4 scores for wound, no ulcer, small, shallow ulcer, and then the deep ulcer and the extensive deep ulcer. And ischemia as again I told you ABI and ankle pressures. So basically more than 0.8 is 0, 0.6 to 0.8 is 1, 0.4 to 0.6 is 2, and the severe ischemia is less than 0.4. And foot infection, again we know infection, local infection, and then the deep infection and the systemic infection, and basically divided into 5 stages. And again 1 year rate of major amputation is when the stage is high, the risk of amputation becomes more. So to conclude, while Wagner system was the first to be widely adopted, it is not well validated, and the University of Texas classification has been well validated and has become widely used, but suffers from lack of reference to neuropathy and ulceraria. And international working group of diabetic foot on diabetic foot was originally developed as a guideline designed to aid decisions for regarding hospital admission, but later evaluated as a predictor of lower extremity amputation also. Overall, system that scored highly for prospective use in clinical management is the latest wound, ischemia and foot infection system, and also especially for the assessment and reassessment of peripheral tissue perfusion. And the most highly scoring system for defining population for audit purposes is SINBA, and this is also again was one of the mostly broadly validated systems. Thank you so much.
Any questions from the audience? Yeah.
Thank you, Dr. Ashu, for coming. Not a question. Yeah, not a question, just a discussion actually. So in VJI also we use
SENBAT for routine documenting what is the stage of ulcer. We don't use Wagner's and UTS. I have burned my hands because initially when he used to send the manuscript for publication, the reviewer used to say, why you have written Wagner's and UTS. We have got away with it. So now we use SENBAT. But I absolutely agree with you that Wi-Fi is the most comprehensive kind of classification that should be used. And earlier we used to believe that in India we have more neuropathic ulcers. But probably our study and recent data shows that it's not true. And if we have the facility for ankle pressure, it should be really done. And I feel that that's the best thing that we can do. In most of our patients, their ankle pressure is less than 70. I don't know why. So that may be because of maybe barefoot walking, they walk a lot, and maybe smokers and so many things. But ankle pressure of this whole story is the most important thing. I don't know how many of us do ankle pressures in this. But yes, Wi-Fi is the best thing.
Dr. Ashu, like, just to your question, please have a seat. Like, in diabetics, one is the calcification is a problem. And we normally overestimate the pressures. And what you're suggesting is they are much lesser. But palpable pulses or not? Absent pulses.
So these patients usually have palpable pulses. So even when their vessels are calcified, so you can have a falsely high ABI, but ankle systolic pressures, for whatever practical purpose, they are usually low in these patients.
Mm-hmm.
And that may be because either they have a lot of collaterals that is forming. And what you are doing at ankle pressure is basically as the PT and the DP.
Mm-hmm.
So that is a major reason. And sometimes ankle pressure can also be false. So now the guidelines are shifting to TBI.
Yeah.
So we do TBI also in our patients when we see that TBI is falsely high and we think that the patient can have some kind of ischemia.
Yeah. You see, that's the issue because normally from vascular angle, if we have a palpable pulses, but there are false palpable pulses. Means some people feel more pulses than normal people, and when the pulses are not there, but they feel it. So that is an individual assessment. So you could be wrong that there are pulses present, and when the pulses are not present. So that is one drawback of that. But if you have very bounding pulses, then AVPI should not be less. Then there is something is not right. And so in most of the vascular centers, so this is my recommendation. Like if you want to have a very advanced diabetic foot centers, which you can have a Doppler and duplex scan ultrasound. Like we all have a duplex scan ultrasound machines. So we actually stopped doing an AVPIs totally. So the moment we see that pulse is not there, the probe is just like a stethoscope next to us. We have 3 ultrasound machines. We just put the probe, and like in 10 seconds we know what is the PSVs. And so that's the best finding and the best setup arrangements. So the moment you see that the peak systolic velocities are more than 30, so we are done. It's like a normal pressure, you can do whatever you feel like. But you're right, in the peripheries we cannot have that system available. Getting an ultrasound machine itself is a challenge because of PNDT Act. So then AVPI absolutely is a must in all this group of patients, for a primary diagnosis.
Yes, may I add to it?
Yes,
So,
please.
The message should not go that AVPI should not be done because
Yeah.
AVPI should be done as recommended by ADA guidelines, American Diabetes Association.
Yeah.
So you're absolutely right. When the patient has ulcer, you definitely have to have a doctor to assess whether the patient is having an ischemic foot, and patient will definitely need a revascularization. But try it. 90% or 99% of patients who are coming into the clinic who don't have a foot ulcer, but they have diabetes, they require AVPI for further triaging them into whether they are at risk of foot ulcers or not.
Yeah.
So guidelines say annually AVPI should be documented in all the patients. We always talk about falsely high, falsely low, but this is again at a 2 standard deviation away from the mean.
Yeah.
Most of the patients still fall between 0.9 to 1.
Absolutely.
But I'll just add one point to this. Absolutely right. We still are doing AVI, but again, as sir described, in diabetes, because of the calcified arteries and all, this toe pressures are more informative sometimes. But I certainly feel from my PGA days and after that also in this subset, this part of the country, so we get more of category of patients that are smokers for long. They are already PAD, never been assessed. Now they develop diabetes and they come labeled as diabetic foot. So they have vascular component is, I feel, even more, as you know, described in the studies, especially in our part of the, you know, our area. Most of the patients come from Haryana, Himachal, and this part. So I feel vascular component is more. So, but again, of course, tissue flow pressures will be better to be, you know, used. And thank you.
Dr. Ashu, I have one, if something like ankle brachial pressure index we are adjusting, sometimes it's coming in compressible arterial disease and we have got a toe pressure, but sometimes toe pressure also gives, sometimes in some cases falls, and the patient don't have got the toe, then where we will get the toe pressures. What's your suggestion about the, if we will just take the, is monophasic, biphasic or triphasic and with the Doppler? Can it be just add up to some clinical assessment or anything?
Yeah, so we always go stepwise actually. Now you're talking about Doppler. So you have 3 phases, 3 examinations before that. One is pulses, palpation. Second is doing an ABI. And third, then you come to Doppler. So if you Doppler, Dr. Ravul Jindal here is the best person who can tell me about what he does when he has a biphasic flow. Not monophasic, not triphasic, but patient is having biphasic flow. So what do you like to do?
No, in biphasic flow, if patient has, we don't do anything. We don't need to do any interventions. So biphasic flow in a calcified vessel is very nice. It's a normal pressure. Okay. So no, you know, see what else happens is, if we are going to follow an international guidelines, which is an American, UK guidelines, you know. So what is the waiting period for Doppler there? So if I, you know, when I was in UK, when we used to see the patient, let's say in January, a diabetic foot patient, the Doppler date will come in June or July, and you will get a CT angio date in March or April. And if the creatinine is normal, you get the blood test reports after 2 weeks, unless the patient walks into an emergency. You see, they have to develop the protocols according to the need, what is there. Nobody could imagine when I told them that we have got 100 ultrasound centers in the city and you could walk into a center and get a Doppler. They said it's impossible. I said it is possible, it's happening in the country. They said we want to visit this country where you can walk into a center and get a Doppler done. Because the protocols what they make, they have, because all the Western world, the waiting period for a duplex scan is minimum of 3 months to 6 months. So they will develop the protocol according to clinical examination, AVPI and a Doppler, because that's how it will work there. Because if they will wait for the Doppler, because what happens is they do the AVPI, at least they will get some reading. If the AVPI is normal, at least they can go ahead with the debridement at the same sitting. But if the AVPI is abnormal, then they can show that this patient is in ischemic foot and they will get a Doppler date earlier for at least 2 weeks or 3 weeks rather than 6 months. You see, that's a difference in scenario in the country wise, and you also have to see the setups. So, but AVPI is very important for monitoring the follow-up patients. So let's say do an AVPI and you need, how you cannot keep on doing a Doppler every year of a patients who does not have peripheral vascular disease. That's also another very important compound. Second is in the peripheries. Doppler interpretation is very problem. Most of the radiologists, they don't know how to do a foot, because common femoral popliteal they know. The moment they go below infra popliteal, intragenicular, most of the reports comes like flow, diffuse calcium. This is standard report. Diffuse atherosclerotic disease, infrapopliteal vessels, and monophasic to biphasic flow. So I cannot interpret that report because they don't write velocities.
Thank you. Now we will move to forward, because already there was a diabetic foot ulcer patient by Dr. Ravul Jindal, because unfortunately he was not able to make it because of his emergency. So we will just let Dr. Ravul Jindal to speak on the stem cell therapy in the diabetic foot and peripheral arterial disease.
Sorry, I am speaking on this. I am not the best person to speak on this topic, but there were 2 problems. The guy who was supposed to speak on this, he missed his flight from Delhi. So he couldn't come, and so I'm just filling in his lecture. So I've just prepared it 10 minutes back. So please don't ask me difficult questions about it, okay? So we all know peripheral vascular disease. We have been talking since morning. There is a huge number of patients with peripheral vascular disease in our country. And we know the standard treatment is risk factor modifications with smoking, blood pressure control, sugars control, and with absolutely supervised exercise programs which we must tell them, these patients, and a medical management which we discussed, that the latest dual pathway inhibition and statins, which is very important part. In few of these patients who don't get treatment, or the patient has got a critical ischemia, so we go for a surgical management in terms of open surgery or an angioplasty, depending upon what the patient requires. But there is a group of patients where we cannot intervene, or where our intervention fails. The group of patients are patients who are unfit for surgery, patients who are got a very low ejection fraction, patient whose relatives actually don't want to even take a 2 to 3% risk of morbidity or mortality during interventions, patients of inframalleolar, means below the ankle diffuse disease, where our treatment has failed. We have got patients with multiple bypasses. We have done 5-6 bypasses in the last 7 to 8 years. Now got blockage from aorta to dorsal pedis. Like there is no vessel, major vessel out there. And patient got very limited claudication, rest pain and non-healing ulcers, where I can't do any reconstructions. So there is a group set of patients where our surgical interventions will fail. So what do we have there? So there is another one set of thing besides which we talked. Dr. Pranay took the lecture in the morning. So besides doing a distal foot revascularization therapies, which we still don't know the data, besides using a calf pump therapies, we still don't have a huge data on this. Besides hyperbaric oxygen, and if you look into the latest guidelines 2024 published, they show hyperbaric oxygen does not have a role. So now it's 2024 guidelines published. So what we have? So the next therapy what we are left with is regeneration. So means we put in some cells into the muscles out there, and what we call the mesenchymal stromal cells, which are derived from the donor bone marrows. And we all know these cells, they make everything in our body, from skin to teeth to everything. So if we can take these cells and put them somewhere into the body, we may be able to regenerate newer blood vessels. So that's the basic concept we are talking about. So these cells has been approved now by the government of India, and there is a company, trade name is Reginsip, and it has been approved for certain indication, not like every patient you put in the stem cells, please. So these are indicated only in a patient with Berger's disease, atherosclerotic disease, Rutherford third classification, where the traditional revascularized positions cannot be done or has failed, and patient is symptomatic. So if the patient can walk 100 meters and there is no rest pain or ulcer, please don't need to use stem cells. So it's a very limited group of patients where you need to put in the stem cells, and there should not be an extensive infection into the foot. I have seen patients with whole of calcaneum necrotic, and whole of stem cells has been put into that heel. So please don't do that, because everything will come necrotic. So necrotic wounds, you cannot use all these stem cell therapies. So how that is work? So the bag which we prepare, it contains stem cells, it contains a plasma light, it contains acidalbumin, it contains a DMSO, and it is stored and frozen into liquid nitrogen, and it comes to us in a bag. And we prepare the bag, we unthaw it, and then we inject it into the body. The possible mechanisms of actions are that actually it causes to improve lot of factors, in terms of biochemistry or biochemically in our body, which results in angiogenesis, immunomodulations like reduction of the inflammation, and it also causes a muscle regeneration. So we don't know it works or not, but there is some literature now and lots of publications on this, that the stem cells does all this. It does help in angiogenesis and immunomodulations and regenerations, and there could be some improvement. So how does it work? So we get them into a liquid nitrogen tank. Once it comes into our operation theater, we take the cassette out, we take this bag out, and we dilute it, and then warm it up, and then make sure that there are no cracks or leaks, and of course it has to be aseptic. So each bag contains around 50 ml of suspension, and we inject it into the calf muscles, and 40 to 60 injections are given, and you can also inject a small volume around the ulcers. So this is how we inject out here, and we may mark it up 10 into 4 grids or 10 into 6 grids to administer the injections, and we try to use 2 to 3 ml syringe, and 1 ml is injected in each place, and each syringe should be administered a maximum of not more than 6 to 7 times, and we need to make sure that it is gone into the muscle, not into the subcutaneous plane, and always aspirate once you inject it, and you can use a 22 to 23 gauge needle, and that is what we routinely use. So this is just like one of the photographs, and this procedure actually we do it in the prone position, make the patient prone, mark it up, and give a small amount of local anesthesia because it is slightly painful to the patient, but the patient can walk home immediately. So we have done ourselves, we have done more than 20 patients in the last 2 years, and with the follow-up results, and we are following these patients up very strictly with everything on a paper, and only 50% of the patients has responded well. So it's not like every patient, 20 patients whom we have injected has shown an improvement. And improvement has been shown in some patients at 1 month, in some patients at 3 months, and in some patients at 6 months. So it varies a lot. So I think stem cells, there is some improvement with the stem cells, but we are not able to predict which patients improve. Or because all these patients are also on the best medical treatment and also on a very close follow-ups, and also we put them onto supervised exercise program. So we don't know actually, is it working because we are following these patients up very strictly because of that, or is it the stem cells who are working in this group of patients. So if you look into the clinical evidence, so this is 29 centers, is a old slide. I think more than 400 patients have been done in the country now, and multiple trials has been done. So if you look into this study design, 24 patients in critical limb ischemias, and look into the healing of the ulcers and the rest pain improvements with a 1 year follow-up, and you see the rest pain is reduced, the ulcer size are reduced, and if you look into the AVPIs and ankle systolic pressures, so both have been shown to get improved on the follow-up at 1 year. And there were no amputations, so there were no side effects in this group of patients. And I think it all depends upon the selection of the patients for the intervention in this group of patients. If you look another study design, which was a phase 4 study, a follow-up for 4 years, and we had 50 patients included in this study, and 2 million units were used, and there were no side effects. So one thing is there from the study we have found, there are no major side effects about once we do the interventions at 4 years follow-up we have, and because it's been approved by DCGI, so we should understand that most probably it's a safe therapy. So it does shows improvement in the systolic pressures and AVPIs, and the pain was reduced, which is a very important factor in this group of patients. And if you look into the ulcer healing, at 6 months follow-up, 68% of the ulcers were completely healed. So in summary, if you look into all this, that it shows that stem cell does work, but not in every patient. And if you look into this, around 50 to 60% of the patients does get improvement, and over a period of time in terms of rest pain and healing ulcers. So this is, example is not my patient, it's been given by the company guys, and this patient has got a plantar ulcer, but I see it's a very nicely granulated wound, and 1 week after that and 2 weeks after the therapy, it is of course showing the healings, and they have shown it walking, and I'm sure in 2 weeks the wound cannot heal up, but leave these slides. Thank you, and we use it in a very selected group of patients, and not in every patient, but definitely it has got a role at present where we are stuck up in terms of treatment. Thank you.
Any questions from the audience? So with that, we are just already running out of time. So we are going to start another session.
Yes.
After that.
Yeah, we can start the next session. Yeah. Dr. Ashu,
So,
please.
Dr. Raj.
Just a comment. We used to work when I was in SR.
Yeah.
Dr. Bansali, we used to do autologous stem cells.
Yeah.
So autologous stem cells, we used to take the bone marrow and then go into the lab, and then we used to isolate the mesenchymal stem cells and then inject in the same way exactly it was done here. So your experience is absolutely right that we also had only 20 to 30% of patients who had some improvement in wound healing.
Yeah, yeah.
And that is expected because all these patients are already hopeless cases. When you have unintervenable peripheral disease, the ulcer is for months. So you can expect, but even if you can heal 30 to 40% of wound with this veganacid,
Yeah.
that's a good outcome.
Yeah. You know, we, from 2007, calls of the CLTI, you can use it. Of course.
They don't approve for that actually.
Is it?
Yeah.
ECJ doesn't approve for diabetic PAD. I don't know why.
Not-
because
not
the
for
trials were
diabetic.
not done on that.
Yeah, maybe.
Well, I have happened to use for a case or two, but hardly you find exactly you said no the unconstructible DVTs
Yeah.
mostly after the PADs, those with long and especially even the company Cipla they recommend for below knee disease,
Yeah, yeah.
and that too CLTA without diabetic is very difficult to find actually.
Very difficult. These are like hardly you will find because you see most of the patients without diabetes in our setup, in this setups are very rare, and I don't know, we don't see much patients without diabetes.
So cost of the product is
Cost.
around
Two
2
lakhs.
lakhs, but this is not for diabetic.
2 lakhs for 1 leg. It's actually talking, to be very precise, is 1.6, and if it's to be used in PGI, it will be like around 1.1 to 1.2, because patients can buy directly, so it's half the cost you. Okay, Dr. Shabdat, please carry on.
So we have our last session coming up. I think we already have chairpersons, and I'll also invite Dr. Chandan Narang, Dr. Ravul Jindal, Dr. Surinder Singh Makkad, sorry, I'm so sorry, and Dr. Ashu Rastogi as moderator for this session.
Please.
I can start from here only. Why should I?
No problem.
That's okay. Moderator
You can see it more better.
Yes.
So Dr. Ashu, you can invite the speakers.
Yeah, please, you invite.
First case discussion will be from Junesh Bagga, Dr. Junesh Bagga, vascular surgeon.
Good evening, everyone. First of all, I feel sorry for those who slept after lunch and they are not here because this was a very informative session. Being a vascular surgeon, there were a few points that even I got to learn, especially from Dr. Bharat, orthopedics team and the plastic surgery team. So anyways, this is a typical diabetic foot case that each and every clinician, not just a specialist, but any medical doctor or any clinician will definitely see there in their OPD. Okay, so I start with a 65-year-old female, long-standing diabetes for more than 20 years. She came to me with a shoe bite, right second toe wound. So it was a minor trauma. So I would like to make it an interactive session. I would just ask you, how would you manage such a case? If anyone can comment.
Unique,
Yes,
what we'll do,
sir.
you present,
Yes, sir.
Dr. Ashurus, he will be the moderator.
All right.
So he will ask the questions.
All right.
Either he will answer himself or he will put in the difficult situations to us.
All right, sir.
And so we are the picks.
All right.
We
Sir.
will be, he will pull us up.
So you are absolutely right. So this is the very common scenario that we see.
Yes.
So I just want to know from the crowd, what do actually they see here? It's few things are grossly obvious here. So anybody
Yes.
can comment.
Bharat, you want to start with?
What do you see?
So
Actually, you can actually point it out. Otherwise, 5 of us, we will not be able to do it. You just point it. Come up. That'll be.
Okay, I'm okay. So we can just discuss what do we say here actually.
First, we just definitely see first we have to look out for assess the patient. Most often it looks in vascular type. We have to assess the patient for the vascularity.
Yes, basically the foot was inflamed. It was warm to touch.
So I would say that typical triad of inflammation is there.
Inflammation
That
is there. Yes.
edema,
Yes.
redness, and
Yes.
warmth. One.
Yes.
Second thing, I can see a kind of a ulcer
Yes,
in
sir.
the second toe region,
Yes.
which is necrotic.
You're right.
I cannot say whether it is ischemic or not because there can
Not
be
yet.
many other reasons for this. This can be just a clot which is looking like a
Yes, sir.
necrosis.
Yes, sir.
But it is likely to be infected. One thing is very clear. Please.
So I put the patient on medical management, and after the next follow-up within a week, this is what she came up with.
I just want to ask a question. At
Yes.
that setting, can
Yes.
you go back?
Yes.
So in this settings, when like if I see such a patient in this, so I can see that the cellulitis is going most probably up to the ankle.
Yes.
Just to add on,
Yes, sir.
and also what was the status of the pulse? Because we will ask, we don't know. We
See,
can't-
because of the edema, the pulse was not palpable. So I had a handheld Doppler. So there were mono to biphasic in the dorsalis pedis. PTA was absent.
Okay.
Patch over the grade 2 also.
Grade two,
So
correct.
that is going
Yes. That
What
could-
was the TBI in this case?
Yeah.
This is an ideal case of to do TBI.
Following,
Yes.
and as we had discussed just
I
some
think
time
it
back,
depends upon the, of course, the infection. If TNC counts and patient, as shown in the picture, infection is settled.
settled.
So I feel revascularization will be done. We can do in the same setting and we can.
Yeah, but what happens is in real world is patient goes to 5 other doctors, and everybody except for me in the city would tell them to get a debridement. And
No, this is a very normal thing. Welcome to the world.
so
So
I said,
show us what happened. Because if you do the debridement in such a patient,
yes,
the whole thing will become necrotic.
Yes.
On table it may look very nice, but I can predict. So the whole thing will become black.
So while we went in for the debridement, there was very trickle flow during the debridement. It was not all that bloody. In a normal foot, if you have ever happened to debride a Charcot like foot, it would bleed like scalp. There is so much vascularity, but there was a very trickle flow in this thing. So at the same time of debridement only, admission, I took them out for revascularization as well. So this was the DSA picture. There was a small lesion in the anterior tibial artery, if you can figure out with the arrow. The rest, all the arteriometry was normal. Because of this lesion, the foot vessels were not well opacified. So once we were inside the system, we obviously addressed this. We did the angioplasty, and there was good flow, palpable anterior tibial pulse after this. Now,
So just before that, I just want to know, because I am not a vascular surgeon, so
Please.
some queries.
yes, sir.
We also see, like everybody discussed, that diabetes have heavily calcified vessels.
Heavily
That can be even from the infra-aorta till the end.
Yes, sir.
So even our vascular surgeons sometimes feel difficult to enter inside when they are such heavily calcified vessels. So
Yes.
how commonly you do a retrograde kind of cannulation rather than in this patient probably you might have gone through femoral.
Yes, sir. This was an antegrade femoral approach. I personally always use ultrasound guidance to make the anterior puncture, and wherever the calcification is less, we enter from that particular point in the common femoral artery.
How commonly you need to do a retrograde cannulation, or you have done retrograde cannulation?
The retrograde cannulation is rarely necessary when antegrade doesn't work, only then.
So maybe we do like 45 to 50 angioplasties a month. We do maybe 3 to 4, but our threshold is very low. So we try for 5 minutes or 10 minutes, and if we are not going, just we puncture retrograde. And so we puncture retrograde into popliteals, SFAs, like you can puncture anywhere. But
Yes, for femoral arteries, retrograde works better because in these arteries they are so small and collapsed because of low flow. It is actually difficult to get a needle precisely into the lumen.
That's what I wanted to know, because that is the problem. Here this patient is probably having a very lower down or ankle disease.
yeah.
So, and the surgeon is, or vascular surgeon is not able to enter through femoral. So this is very, very tricky to enter into these very small vessels.
So, if you are, of course, you need to be good in ultrasound and retrograde punctures, but there has been rare cases where ultrasound guided puncture retrograde we couldn't do. So what we do is we expose the vessel and do, because that vessel moves with the needle, the needle doesn't enter. So we actually loop the vessel and do a percutaneous puncture, like open the vessel, control it, and then do needle puncture, and then do everything endo, and then like we don't open the artery. So there has been cases where we actually open the dorsal pedis. It's like a stone, you just cannot go. And somebody has tried. We thought we are very good, we will cross. So we always are, always think we also fail. Like stupid people. And then we opened the artery there and did an endarterectomy. And then on table, after doing an endarterectomy, then we do a proximal and distal angioplasty, and we did a patch on the dorsal pedis, on the posterior tibial, not on the peroneals. At the ankle level.
Yeah, but of course, retrograde sometimes when you fail, as he clearly mentioned, if you fail a antigrade, then only we go for a retrograde. Sometimes we've seen retrograde wire goes like anything. So from above we are trying for the last half an hour or more than that, and once you do the retrograde wire goes like within a minute only. But I would feel, especially the tibial vessel, sometimes you have only a single vessel, patent, which you are trying to open. So unless until it is, of course, antigrade you can't do, you've already, finished your resources, then only we do, because dissection and all those things, of course, can happen. And patient can land up in more trouble rather than, So I think everybody has burnt their hands. So very cautious, as already Dr. said, sometimes patch, plasties and all, of course you can do.
Okay, go on.
So we have done the debridement, we have done the revascularization. Now we are up to the wound management part of this thing. So the patient is getting daily dressings and on follow-up, and the patient comes back with this. The other two toes are getting gangrenous now. So we do further dressings, we let them demarcate because it was a dry gangrene. There was minimal slough in the wound at that time. So probably we thought proper glycemic control was also one important aspect of this thing. So finally, after some time, patient came up with this thing. Full-blown sepsis, raised TLC counts, HbA6, and the forefoot was totally involved with this thing. So it happens when you treat a patient for a very long period of time. Eventually, some complications happen during follow-up because from where they get dressings, how they keep their glycemic control, and it's multifactorial.
So I just wanted to know, because when we did the first amputation of the second toe, actually the bones must be exposed, and probably this bone is extended till proximal area, maybe through the fascia or through the bones, maybe through tendons also. I was just thinking that probably could MRI have been done at this point just to know what is happening to the tendons and the ligaments. I just guess what.
Seems otherwise unlikely that they know everything is settled.
Yeah, everything was fine actually.
The bone is exposed.
Yeah, the bone was exposed. We put in a vac here. We did a vacuum therapy once. The granulation tissue appeared after this here, and it was all going well until the patient suddenly came back with. Yes, we did one cycle of vac. So we started with 75 on the first day, then next day we increased to 90, then 110. 110 we maintained for next day. Yes, sir.
Ischemic pain, when you also in the lower side. You cannot just go on increasing. That
Yes,
is
sir.
the important thing because that can lead to further necrosis.
Yes, sir. You are
That
right.
pressure can add on and it can lead to necrosis.
Yes, sir. You are
So
right, sir.
that negative pressure is very important.
Yes, sir. But I made sure that.
And even that can be put on intermittent mode
intermittent.
so that the tissues get relaxation in between.
Right, sir.
Yeah.
Another question I have, like we have done a procedure, like angioplasty has been done. How do you next assess the vascularity of the patient daily basis? Because this patient likely was admitted.
Sir, as I showed you the anterior tibial lesion that was dilated, I had a pulse. I had a palpable pulse, anterior tibial pulse, and I also follow up with the handheld Doppler for the flows.
So what's the role of TCPO in this case post angioplasty?
TCPO2, yes, it is a very ideal investigation. Readings of more than 40 show good ulcer healing, good outcomes, and I think less than 25 or so may predict the very high risk of amputation.
Ravul, do we use TCPO?
No, we don't use it in our clinical practice. If we have, it's nice. But if you have on Doppler, because every time the patient comes to our clinic every 5 days, we just do a Doppler. It's an ultrasound machine, not a Doppler actually. Handheld Doppler, it's a like ultrasound machine. And if we see a pulsatile DP at the ankle or a posterior tibial at the below the malleolus, the wound will heal up. Now TCPO2 role is that, let's say it's such a wound, you do the revascularization. The TCPO2 is for research purpose, is very important. We do not use it in the clinical practice in day to day. And the reason is because there are some issues with the sensitivities and specificities for that part. Because let's say if you have an infection, the foot will be warm, then the TCPO2 will be falsely positive also. So, but in general, if you put in a TCPO2 below the ankle, at least if your values are on the higher side, if you think the circulation is good, you can predict that this wound will heal up. So it's a, if it's available in the hospital setups, and it's an expensive machine, 5 to 6 lakh rupees, and if it's available, and then it's a very good tool to use along with the duplex scan to predict that the wound will heal up or not. The reason is because you could have a normal DP and a posterior tibial on the ultrasound and a low TCPO2. So those are very rare group of patients where there is an extensive microvascular disease, especially in patients with CKD, where the wound does not heal up. So those are the group of patients where TCPO2 will really, I feel, it will be very helpful. We don't have that available, and it's it's a tool which we should have. It's about how to charge the patient for that. So that's where we are stuck up. It's not slightly expensive, so yes.
We have this TCPO, but again, as Dr. Ravul is saying, the consumables are really costly. So we have to put at multiple sites actually, and each site, once you do TCPO, costs to the patient. So that's a problem. Another thing that I wanted to know, like you have presented very nicely. So now this patient is having a worsening disease, we can see it. And what I presume, this is my opinion probably, this might not be because of ischemia. Now this is all infection that is happening, and that is going proximal.
Yes.
So what is causing this infection? Either the patient has poor offloading, patient is not doing right dressings, or patient has abscess or underlying osteomyelitis.
Poor
agree.
glycemic control probably.
Absolutely. It could be a combination of everything. So if I see a deterioration of this is not uncommon. And this we see in patients who has been actually put on blind vac pumps, and the patient they delayed for like 5 to 6 days, and the tissue, can you see on the first picture, the tissue has covered up, and inside the cavity the infection was rolling in, and suddenly the infection went along the tendons on the posterior spec up to the ankles. This is along the tendons which has gone. And so this is a very common scenario which we see. It's not uncommon really. And what we have found, this happens if you apply the vacuum for too long. If I try to see every wound, but if I miss it and I see such a wound, I see, oh, the wound is closed from the top, and surrounding toes are getting necrotic, means the infection at the metatarsal level is getting spread. It's not coming out, it's getting spread, and it's causing the digital necrosis, and half of the digital arteries have got necrosed, Also, I will like to do immediately a Doppler to make sure that my anterior deviate which was running, it
That
was
was
not
fine.
blocked.
That was fine.
You know?
Actually, that marginal necrosis definitely shows it's because of valve. Reason? Because
Yes.
there is already one side vessel is already gone.
Yes.
It's already only surviving on one pedicle, and other side is just by surrounding tissue, some which is already ischemic. And if you put VAC over that, and that margins on both great toe and third toe, they are black. It is because of VAC only.
Yes. Like,
This is how long after presentation?
I think this was a 1 month after the debridement or this thing, because
And vascular status at this point?
vascular status was fine. The anterior tibial pulse was good. So this was purely infection at this point.
And another point, sorry, I forgot to make. You also see if you stop the injectable antibiotics
Yes.
more early. So
Yes.
if you, that's another point. So what we have modified our protocol is we don't stop the injectable antibiotics too soon,
Yes, sir.
unless I am 100% sure. So if I see, so now we are very standardized thing that we don't just stop the IV antibiotics early. At least such a patient which you showed me, at least 2 to 2.5 to 3 weeks of injectable antibiotics will go in.
Just go ahead, please.
So now the question is whether to let go of the limb or because the other doctors have advised ये तो जाएगा below knee amputation की मतलब there are very high probability of a below knee amputation versus a attempt to do a 4-foot amputation and then do this thing. So we did a 4-foot amputation. You can see a proline suture at the anterior tibial dorsalis. So again, we are left with wound management. Now this wound management is after 2 months. We gave multiple sessions of that. I made sure the antibiotics are there in place and the glycemic control is strict and so forth. It's a 4-month follow-up. The patient underwent 1 more session of debridement where up till the heel it was opened up and the remaining tendons were removed. And this is the final picture. The patient actually got away.
No, but the issue is this wound is not stable wound. In any case, whatever you got it healed or it's in a small wound,
This
is not going to take the weight. It's going to be unstable and repeated ulcerations are going to happen.
yes, sir, it is unstable, but for the time being,
It is just sorted out, but
Yes.
it's going to have problems.
So what else could you have done, like in the previous one?
The only issue is if the now vascularity is sorted out. If infection
Yes,
is
sir.
controlled and the patient has been amputated, then it should be given a cover
cover.
with a flap. Yeah.
So what's let's go to the previous picture. Previous picture. Yeah.
Yeah.
So at this stage, what will you do?
Yeah. At this stage, if vessels are okay, then I will definitely put flap.
Yes, sir.
Any flap, fasciocutaneous flap will be good enough. Anterolateral thigh flap or any flap, fasciocutaneous flap will put on vessel.
Instead of the skin graft, you will prefer a flap, right?
I will prefer a flap, but obviously it all depends on the patient situation and how the doctor is coming out of that situation.
Yes, sir.
You just want to just sort it out. So that is the kind of situation. Otherwise, this wound needs flap.
Just three flap. That will be the best thing.
Yes.
On the top of the flap.
Yes, definitely.
I actually considered that because if you see the angio, there is no posterior tibial artery of the patient. So any rotation flap or this thing was not actually advisable because of the poor vascularity calcified vessels.
There is no question of any
Yes,
that
sir.
kind of rotation of it. It's a microvascular free flap.
Yes, sir. Yes, sir.
That you need to decide which vessel is working. And obviously which vessel you have treated, which I was just discussing that time previously also, that which vessel you have recanalized and what is the window period you are going to have, otherwise it is also going to get thrombosed.
So in a densely circumferentially calcified artery, is it okay to,
No, if it has good velocity, calcified vessel it won't pulsate. but
Yes, sir.
it will have at least have good flow.
Also, Swindra was saying that you can actually do the flap with the perforator vessels also. You may not have to touch the main vessel, right?
Yeah, that is still under that is super microsurgery kind of situation. That is not.
Okay. Okay. And once you heal up, last one. Let's say we have this situation. Bharat, what should we do? Like I know it's an unstable thing. Last one. So now what should we do? We are stuck up here. Let's say.
So definitely he or she needs an offloading definitely. If the circulation is all right, just as he says that the vascularity okay, we can just give her an filler with an AFO type, and in that way removable. We should not use DCC in this processing because it was already infected and vascularity was compromised. So we can use an AFO ankle foot orthosis with filler and offloading at the bottom.
Okay. Yeah.
So I think should we move to next case?
We only two cases.
That's last.
I just give the other option also.
Yes, sir.
Sometimes we allow patient to earn the flap, right? That you have come out of the that situation. Now patient is having unstable cover with ulceration, repeated ulceration. Then you can now propose that it can be covered with the flap.
Okay.
Now situation is settled and wound is quiet, and you can now give the option.
Perfect. Thank you, Yunesh. Thank you for a fantastic case. Piyush, please come.
So two
Please, Vishal.
questions I have
Yeah.
regarding this case only. So like of course it's a nightmare, you have a patient will of course say, okay, I came with the full foot. After 1 week, gangrene is there. So what else could we have done at the first sitting? Because sometimes ischemic foot also they become red. Before gangrene they become red and
You see, we lost the foot because of infection in this case. And I think the lessons to learn out here is back at a lower therapy pressure. Not make sure that the bones are clean, repeated X-ray. Make sure that you follow these patients up very closely. We follow all these open wounds every 4th day. Or sometime when I'm not happy, every 2nd day, alternate day. So I maximum 4 days. And every 4 days I make sure that I personally see everyone. You can imagine. And the reason is because the eyes, they can. I have done every possible mistake in the book which is written, so I can pick up the mistakes very fast. The wound is closed, so you can see, oh, skin aa gaya, bahut acha lag raha hai. But you see something is wrong, and then you open the wound, get the pus out, start injectables earlier. Repeated cultures is another very important point. What we have seen is the patient is on very high doses like marathon and targazide, and patient's wound is very healing, and suddenly 4 days later you come that the wound is not looking good now. And the bacteria has totally changed because patient is doing the dressing 2 times out there in their local setups, and so the culture and the bacteria and the wound is totally changed. So repeated cultures is very important, and repeated, if you think that clinically the wound is not responding, then change of antibiotics. Because it's all about that spread of infection which could have been stopped.
Yeah, exactly. Just 2 small points. Okay, on first presentation, would you like to do MRNG or something for that patient if you have on Doppler monophasic?
You are asking me?
Yeah.
Okay. If
Monophasic.
If the patient comes on the first day,
Monophasic flow.
we do everything in that 3 hours.
Yeah.
So
Same
everything.
we follow.
Next morning, we try to put these patients on that day very high strong injectables. Next morning, angioplasty plus diabetic. Something. So I am very aggressive, and because we have learned that if you are, if you just stay, then it goes.
Same exactly, because you don't want patient coming after 1 week and we feel something could have been done that would save. And another point targeted artery pathway and angiosome concept we are following. In this patient, PTA was severely diseased. So would you, in the same setting, would you like to do something for the PTA also?
Yeah. You see, try to open up as many vessels as possible.
Yeah, exactly.
So my principle is we take the long sheet up to the popliteal and then see which is the easiest vessel to open up subsequently.
Exactly.
So open the easiest vessel first, then the next,
But of
and
course,
then go for the total occlusion vessel later on. And you try it for 15-20 minutes, and you need to look into 2 or 3 things. One is contrast load. So you're not putting in too much contrast into the patient because septic patient. Second is the patient should not be in the anesthesia for a very long time. And you try it, and you know with experience you know in 10 minutes that will you be able to open this vessel up or not. And if you know that no, then you just leave it. And if you think that you can, then why not? So the larger the blood supply to the patient, the best it will be for the patient.
yeah, of course, and you want to do it in a single go. You don't want to go again.
Definitely, all in one go.
Yeah. I think that those things could have been done, but sometimes we've seen after doing everything, you still get this result. And
We also lose patients, we also lose legs, definitely. Let's go to the next one.
Thank you,
We are running late now.
Dinesh, and we just call now the Dr. Piyush Chaudhary for the next case.
Good evening, everyone. So again, I'm going to present a case. Here we had a 62-year-old male, Mr. JK, with a history of diabetes. He was on regular treatment with controlled sugars, also hypertensive, and he came with some foot condition. I'm going to show the pic. Also, he had a lap cholecystectomy, and when he came to us, he had gangrene of all the toes. Simultaneously, when we saw this foot, obviously we knew that something is not right with the vascularity. Being, a vascular surgeon and working in a vascular unit, you just know that this kind of foot you must investigate for the vascularity. So as our protocol says, we examine the patient clinically, and obviously pulses comes first. So clinical examination and pulses, obviously, we found the femoral pulse, popliteal, and below that we didn't find any pulses. So the first thing we did was investigate all the blood investigations, and we found out that he has some acute kidney injury. His creatinine was around 1.5. So according to our protocol, 1.2 and above 1.2 we don't go for the CT angios. So we avoid that, and obviously we went for the MR angiography. So as I said, we did all this pulses, capillary filling, ulcer and gangrene we checked. ABPI I have mentioned here, and we have discussed already that we don't use it for the obvious reasons that Doppler is readily available with us and it is superior than ABPI, so we directly go for the Doppler. And again, Doppler we do when we have some suspicion that vascularity is plus minus, but for obvious reasons when popliteal pulse is there and below the knee we don't have any pulses, we directly go for the angiography, whether it be CT or MRI. So here is the, it's MR angiogram, wrongly written venogram, and because of the acute kidney injury, we did MR angiography. So obviously we saw that in this case we had a good blood flow up to popliteal artery, and below the knee we had the disease. So we went for the angioplasty.
You want to stop him or go for questions?
So just for the audience purpose, like in which scenario, you showed one scenario that it is acute kidney injury, therefore you went for an MR angio.
Yes.
Why not MR angio in all patients with diabetes? Because they are at risk of AKI anyway.
So, please answer.
There is a risk, yes, but we have seen, like in clinical scenarios also, that CT provides a better picture infrapopliteal vessels. And
Actually talking nearly 90% now, we are actually not doing MR contrast also. So from 3 years, 3 years back, I just saw in one of the European meetings that there is an MR non-contrast thing. So I came back within a week, we got an MR non-contrast, 4 years now, MR non-contrast launched software. And 4 years now, nearly 90% of the patients are done MR non-contrast angiograms. All patients, as a routine, 90%. The only reason we will not do an MR non-contrast is because the waiting is a problem. Only waiting, because the patient is come from Bathinda or Sissa or somewhere. The patient has to go back in the same day. And sometimes the MR waiting is like 6 to 9 hours. So if the treatment is normal, MR, but if the MR is like available, we are not even doing contrast. So MR non-contrast is amazing. It actually gives you the similar pictures as CTs and MRs.
Exactly. I agree with it.
And exactly my reason would be the second reason would be the same, because in a private setup the patient wants the same day and we want to investigate him, send him home with all the preparations. So CT is fast, and in our hospital MRI there is already long wait.
Okay. So theoretically speaking, suppose diabetes patient are prone for heavily calcified vessels.
Yes.
Again, CT versus MR, non-contrast.
So
MR
yes, if readily available, then we will go for MR.
It is available, suppose.
Yes, for obvious reasons, first contrast we won't be giving, and
Because we are expecting heavily calcified vessels. That's what I am asking.
so MR we will go.
You see, one investigation will never suffice in all these patients. So you do MR non-contrast, MR contrast, CT, below the calf, this interpretation will be like this. So you need to combine that with your Doppler and the imaging findings. So you cannot just have, sometimes people send us like, Dr. Sir, वो MR picture भेजिए, please उसको देख के बताओ इसको. मैं कहा sorry, I cannot tell. I need to see the foot, I need to see you clinically, and then do a Doppler. So because all these have got false positives and all in the distal foot. So we will judge it, but we cannot be 100% sure.
Like sir said, obviously whether we have CT angio report or MR angio, we have films. So even then we cannot say obviously 60-40 dilution. So very less contrast, less than it's around 1 ml contrast. It takes 1 ml for there and 1 ml for around the ankle. So approximately 2 ml contrast it takes. So we took the angiogram here where we saw the posterior tibial artery totally occluded from the origin. Only runoff was this peroneal artery, and anterior tibial artery, as you can see, multiple narrowings, and after proximal half or proximal 1/3 it was totally occluded. So, and at the ankle, the only vessel was peroneal, but it has a branch which was filling the dorsal pedis artery. So again,
Just to elaborate further, what is the sensitivity of carbon dioxide insufflation angiography versus maybe an MR non-contrast? In this scenario, definitely you needed carbon dioxide insufflation because of AKI.
yes,
Otherwise, how commonly you do it, and what is the image that you get versus maybe MR?
you're talking about the MR angiography.
Contrast. MR contrast.
MR contrast. So CO2 again we have a very low threshold. We have readily available CO2 angiography. So whenever we see there is a reason to do it, like acute kidney injury, we go for it, and the image quality is very nice actually. So if you go up to the popliteal vessels, it has a very nice visibility. Even if you put a catheter up to the popliteal artery and then do with the CO2, even then you have a good visibility of the infrapopliteal vessels. But sometimes you can miss a lesion. So with the catheter, very low contrast below the knee, we take this contrast angiography.
Any contraindication for carbon dioxide insufflation?
It has above the diaphragm, we don't use carbon dioxide.
Definitely. Any other content, just for knowledge purpose, just discussing.
Mm,
Otherwise, no.
I can't think of.
That's it.
We can use it actually nearly every patient, and some patient maybe respiratory disease they may have but the amount of CO2 you use, then you put these patients on slightly more oxygen and therapies, but very rare. And CO2 is amazing. So we started using it like 14 years back, 15 years now. So we have trained ourselves so well that it takes us like less than a minute to set up the CO2. So it's a very low threshold. We use a combination. CO2.
No risk of embolism.
No, absolutely not. Zero. So we must have done more than 1,500, 2,000 cases this year.
So in this patient, obviously, there was only vessel which we could, go was anterior tibial artery. We could try to reconstruct it because it had a major collateral from the peroneal which was filling the dorsal pedis, and there was multiple narrowings in the anterior tibial artery. So we went into the anterior tibial and did the burning of that. We did not try this posterior tibial artery because from the origin it was occluded and distally it has only the large collateral. So for obvious reasons we should not touch it because we can ruin that also. So this is the result post angioplasty. So we could reconstruct anterior tibial artery as you can see from the proximal half, and distally there was a narrowing in the third picture we can see. So there was a little bit narrowing, we treated that also, and then we had a good flow up to the foot. So we did that and we did not touch the posterior tibial artery. So blood supply was restored. First, second and third toe amputation was done, and we saw that infection was spread up to the metatarsal bones of the fifth and fourth and fifth. So we removed them also, and this happened after that. So bones were necrotic again.
This is a good, I told him to present a difficult case, failure cases, rather than just showing success cases. This is easier. So, this is a very important case. He was healing very nicely, and 2 weeks, vac pumps were applied, IV antibiotics. We were just about to stop the IV antibiotics that he started on the third day of the third vac, he started complaining pain. So we said, okay, let's remove the vac because he should not have a pain, which was not there before. And open the vac, so it's necrotic. So now that becomes an indication because where the sepsis was settled, creatinine became normal, everything was normal, and suddenly he started having pain there. It means the artery which you opened up is gone again. So, so we took the patient immediately for angiogram again. So, because the moment you see any no signs of sepsis and pain started coming back, which was not there, and patient opening the wound, it's black. So means arteries which we have opened up, closed up again.
So that is the highlight of this case that you presented. We always believe that if we are opening a proximal vessel, we believe that the distal circulation would be good.
Yes.
But that doesn't happen in diabetes. Diabetes is a microangiopathic disease which involves mainly the distal vessels, and it is known that it is mainly infrapopliteal disease. So that's what I was mentioning about TCPO2s. Like, suppose you would have done a TCPO on the third day for this patient while you were applying VAC, would the outcome be different? And second thing, the bones were again exposed. I am really fearsome of bones. When the bones are exposed, the wound is likely to go proximally, and it is rapidly travels.
Not always it happens because now we got huge. I used to, whenever the bones used to be exposed like this, I used to say like this will go. Now let's remove the bones, and all these bones will become necrotic. You'll be very surprised because so many pictures we can't show it. One by one we'll put in those cases next time. Totally necrotic bones, black. You feel it's like gone. You keep on booking the wax. The whole granulation tissue comes on the top. The whole skin graft takes off, and we got like 2 years, 3 years. People are walking, and calcaneum total black, and so we just keep on removing little bit black, and the granulation tissue just goes up. I think in this patient also, all these bones you can see we didn't remove. We didn't remove these bones. Everything has come out.
We can have a plastic surgeon's opinion actually. Our plastic surgeon, whenever he sees a bone that is necrotic, he says, kindly remove it, I cannot put anything over it.
Yeah, of course.
Obviously, we cannot leave the, first of all, it's viable or dead.
Yeah, that's it.
That clinically you have to judge. If it's a viable, obviously then if what amount of bone is exposed, that is also important. It's a small amount or it's a big bone. What you are going to do with it? If you are not going to use it, if you are not going to cover it, then it's better to remove it. Why we are going to keep this bone? It's going to get necrosed in any way. So if it's a small amount, yes, and it's viable, then granulation can come out over that. And as I had said in my presentation also, that those that matrices, normal matrices, they can be used for small areas of bone where rest of the thing is granulated and that bone is viable, you can just put small amount of that tissue, it can help in bridging.
Yeah, that's what we did.
Those kind of small things can be done.
Yeah.
Not all, obviously, if the big bone is exposed, we are not going to make use of that.
And I agree with Dr. Ravul that when you are talking about calcaneum, if you have to do everything for calcaneum. If calcaneum is gone, only option is BK.
Yeah.
So in that case, definitely multiple wax, if granulation occurs on calcaneum exposed, that's a very good outcome. But for maybe these kind of metatarsals, I don't know, let's show, let us
Just a point to mention that when we have a single vessel and we have a proximal disease and very severe inframalleolar disease, sometimes we are not very aggressive in a single vessel. Because if you do a lot of things, you can just ruin that also, and then you can end up with an amputation. So maybe one reason that we got there with the wound situation, maybe we opened the proximal section also and the distal also, but not so aggressively, maybe. So maybe when we went to next time, we will see what happens.
What was the criteria of using the VAC on the same day or just post
Next, 48 hours.
48 hours?
24 to 48 hours.
And what was this pressure level you just?
We maintain a standard, 70, 80, 100, depending on the pain tolerance. But we don't go like the full venous ulcer type, open back pressures. And this actually patient, we were about to discharge after 2 days because he was in the hospital for 10 days and he didn't want to go. And this is a very tricky patient. And keep on going still.
So redo angioplasty again.
angioplasty in the same vessel?
I will just proceed with that. First point is, by the time we reached to the second angioplasty, the creatinine was normal.
Right?
So that's why we did the conventional contrast angiogram, and again SFA normal up to popliteal normal, and here again we can see there is some narrowings in peroneal also, and proximal narrowings in anterior tibial, posterior tibial again totally occluded.
You can point out actually for the audience.
Okay, so here is the SFA running well, and then up to the popliteal artery. Then here is the popliteal trifurcation here. This is the anterior tibial artery with narrowings, peroneal artery, and here total occlusion of the posterior tibial. Here we can see the peroneal artery in the middle with the collateral. We will see distally here filling the anterior tibial artery, and there is a big collateral. So that's the reason I was telling before, we did not want to touch posterior tibial. And here is the multiple narrowings of the anterior tibial again. So again we did the anterior tibial angioplasty. And this time, and peroneal also. So this time we were able to open it, and we had a good contrast runoff in these vessels. And here we can see a lesion here which was treated, and then we had a good flow in the foot. So this was the second time we did the peroneal, the anterior tibial, and this distal lesion in the anterior tibial artery. So we went ahead for the debridement again.
Now see this picture, on that black picture, all metatarsals were black. So what we did, we just opened the blood vessel and just cleaned the superficial layer of that black thing. And this is on table next day, and all that black thing which you see. So what we realized that what you see on the black thing on the bone is sometimes just the periosteum or the soft tissues which are there. They turn black. They look like the whole bone is gone. But the moment you improve the blood supply, the whole scenario changes.